So our next speaker is Debbie Gunter, who's going to talk to us about palliative care. She is the palliative care expert at Emory Hospital. She's going to talk to us about difficult talks and how those work in the ICUs and her experience with that. So thank you, Debbie, for coming and sharing with us.
It's good to be here again. As a former critical care nurse, clinical nurse specialist, now family nurse practitioner, but never have done family, geriatrics, and palliative care, and at Emory for the past 9 years in the inpatient setting. So I know a lot of you in the room, so it's good to be here again. And I appreciated hearing the questions from the first talk about DNR and pressors and what do we do and all of those pieces, which clearly they tied us, the three of us together because they all feed into each other about how do we communicate with patients, with families in this age of patient family-centered care. And certainly for those of us within the Emory system, we are all in it together is our tagline. So we're all here and we're in it for the patients and families. So a lot of years of experience for me in this whole field, 37 years. And sometimes we do it really well and sometimes we do it terrible. And so I hope to give you a few snippets of how can we do it better, and looking at that approach to difficult conversations, although how we define difficult, not quite sure at this point. And then how can we help in shared decision making, help with families, patients to come to a consensus of what the goals are. And I thought I had a slide in here about I have no possible conflicts at all. Maybe I wish I did, but I don't have any. So I thought that was in here. So clearly, patients come with families most of the time. There are patients that are surrogateless, as we were talking about with the first talk. But family systems is not something that the majority of us probably got much education on, whether it was a long time ago or fairly recently. And who makes up a family clearly is very different for different individuals, whereas biological family, adopted family, friend family, whatever it is. But when our patients come to the ICU, they're not usually coming by themselves. And often, clearly in the ICU, we end up dealing more with families in terms of communication than with the patients in at least 50% of the cases that we see. And families come with often very different ideas, very different experiences than what you've had, what I've had. And part of effective communication is trying to find out what their family process is, what their family experiences are. And as I was saying, the majority of us probably haven't had a lot of training in family systems and family system theory. And to be successful, we really do need to spend some time, whether it's 5 minutes, I'm not talking about an hour's worth of time, but when you look at who's at the bedside for the longest period of time, it is those of you who are nurses in this room. You interact with the families, whatever makeup that family is, more than anybody else on the team. And you're constantly getting little snippets of information about the family. Some may be correct, some may be incorrect. One family member says this, another says another thing, but you're getting a lot of information that often is really a key in understanding why this family might be making some of the decisions they're making that we are perhaps in conflict with. So that question earlier about, yes, they have a DNR order, but they're on high-dose vasopressors. just going on, and we're watching their digits necrose. What do we do with that? We all want there to be a system that says, okay, boom, 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 we get to stop this, 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 and this. Can't you see, family, what is happening to your loved one? We see it, therefore you should see it. But lay people don't see it. They don't have the training to see it. You and I went to school for a long period of time to know what we know, and all the years you've been doing whatever it is that you do. And yet, often we expect families to get it on the first day of their loved one being in an ICU, or a second day, or a third day. And they can't. They literally can't. So trying to figure out the dynamics, figure out who's who. Number one, just figure out, is there a legal surrogate decision maker? And who is that person? Certainly in emergency situations, we're talking to whoever is there. But 5 days into an admission, we shouldn't just now be finding out that this patient, whose mother has been making the decisions, actually has adult children who are the decision makers. We shouldn't be finding out 10 days into an ICU admission that actually this patient is still married. Spouse is not there. They may have been separated for 15, 20 years. That spouse is still the decision maker. And so being able to help families see what's happening doesn't happen in just one interaction. As part of the palliative care team, I thought I was going to hear when our first speaker said, would you change this patient's status? That's right, when I came into the room. Would you make him a DNR? What would you do next? And I was expecting somebody to say, call palliative care, but I didn't necessarily hear that. Often when we meet a patient and family, and I come out of a meeting and I've been met with from the ICU teams, did you get the DNR? They don't really understand what's happening, do they? And a lot of times my first meeting is just, hey, how are you coping? Oh my gosh, this is just such a shocking, horrible situation, and I am so incredibly sorry for you. How can we help? Sometimes it goes a different way, but when we look at all of the factors that influences what a family is dealing with and how they can possibly cope, what is the actual illness that's happening? Is this an illness that they've been dealing with for 20 years? And in our mind, we think, well, you've been dealing with this, so you should be prepared for this. Not. Is this bye, honey, this morning, I'll see you tonight, and massive intracerebral hemorrhage? Massive PE. I'm still with my loved one this morning saying, bye, honey, I'll see you tonight, when you're coming to talk to me about how this person is not going to survive. You don't know my loved one. He's a fighter, right? How often do we hear those words, right? So what is the actual illness? I put on here again, the family structure and roles. And we've all been in situations where one person might be the unofficial decision maker, isn't the legal decision maker. Certain cultures, certain religions, you don't talk to them, you talk to these people. So we have to sort of navigate all of that, but that's part of what they bring to us, their spirituality, their faith, their religion, whatever it is. And I may not know what it is. I don't know, therefore I need to ask. Cultural views and beliefs. I remember getting a frantic call one day from the CCU. And they were all up in arms about a patient who was dying. And the family had sort of said, you can't move the body for 4 days. And everybody was up in arms. We can't tie up an ICU bed with a dead body for 4 days. Oh, blah, blah, blah. So it was, Family didn't speak English, got an interpreter, had a meeting with them. Guess what they thought was going to happen and why they wanted, some of you are here, you might remember this case, why they didn't want that body moved for 4 days was at the end of the meeting, and I thought it had gone well in my little mind, when finally one of the daughters said, so when will y'all come and cut out his organs? I said, what? She said, yeah, when will y'all take his organs? Because we were told in this country that that's what y'all do. So they were going to stand guard because part of their religion and belief system was the body did need to be undisturbed for the spirits to be able to go and do and whatever. But once I explained no organs were being cut out, the body could be moved to the morgue and undisturbed in the morgue. Who would have thought that, right? That's what they were thinking. How do they communicate within their own family? And sometimes that takes some time of seeing them together, right? Some families are yellers. Some don't talk at all. Some are, I got to talk to every single person and I've got to call 15 great aunts before a decision can be made. Socioeconomic factors and resources. We are often quick to judge. I'm sorry to say that about us, including myself in this room. When family isn't present, we judge and say, oh, the family's not coming. When the family's there, they're there too much. Why aren't they working? We can't have it both ways, y'all. What is their past experience with illness, serious illness, death, disability? Is this, many of y'all have had this patient, disabled childhood illness, and now the child is an adult, but mom and dad have fought systems, fought for resources for this child who's now an adult, but still a child, and we think we're going to make some headway there when they've been fighting for this loved one for 30 years? Do we know? I remember talking to a wife whose husband, multi-system organ failure, in the ICU on the vent. We're doing all these horrible things. He's blowing up. He's necrosing his fingers and toes. And she said, I cannot lose my husband. We just buried our son. There was no way. So then how can we shift and still support her? Still treat that patient as a human being, but still honor where she was. But if we don't ask, we don't know. This is not, what y'all do is more rocket science. What I do is less rocket science, but more, what do you mean you haven't asked who that person is in the room? Have you talked to them? I went to talk to a wife one day, and I said, tell me about your husband, because he was intubating, couldn't talk to me. Tell me about him. And she looked at me, and she said, do you mean everything that's wrong with him? And I said, no, everything that's right with him, everything that makes him this man you love. Who is he? We don't know who he is, right? Those of you who have worked with me through the years, I'm always telling families, bring pictures in. It's getting harder because they're all on the phone, right? But we need pictures. We need to be reminded that this is a human being who is in our bed. May not look like one with everything that's happened to them or what we're doing to them, but it is a human being who has lived an entire life, often, before we ever know who they are. So in palliative care, a major part of what we are committed to is to hear the story. Because if I don't get the story, then I can't connect with you, and I won't understand perhaps why you are making the decisions or choosing to not make a decision, which is making a decision. So being able to get families together, I'm proud to say through these last 2 to 3 years, family meeting, our whole HRSA grant with primary palliative care, trying to increase that integration across different units in the Emory system, not all in the ICU, but within the MICU, probably the most successful And then in the surgical ICU, of making a commitment, having a bundle, in addition to the sepsis bundle, but a bundle for how can we integrate palliative care, patient-family approach, and actually do it like the sepsis bundle. On day 2, on day 3, on day 1, what are our goals? And so having family meetings is really an important part of all patient care. Because again, if we don't understand what the goals are, what this family understands about what's wrong with that patient, right? I'm sure all of you have been shocked when you said, tell me what you understand about what's happening right now. My favorite, I get to say, what have the doctor said to you? What have they told you? And they talk, and you're like, oh my, we are worlds apart here. Or they totally heard it. They're hearing it. It's sinking in. Purposes, again, sharing information. What do you know? What do we know? Let's share that information. Family dynamics, trying to connect, trying to reach a consensus. We don't always. And discuss conflicts. Those are the major purposes of family meetings. Barriers, we think we don't have a time to do them. Do we get to get reimbursed for them? Actually, you can bill for family meetings as part of your patient bill and extended billing codes. Scheduling, who's here? Well, because if we're going to have a meeting, I need cardiology, I need surgery, I need hepatology. And how easy is that to get everybody on the same time frame? And then we have to figure out when the family can be there. So it is not an easy task at all. Easy to say let's do them, but it is difficult. Sometimes not everybody's as committed. Oh, I don't need to be there because their organ, my organ system is fine. No, liver doesn't need to be there. Surgery doesn't need to be there because they did the surgery and they're done. And on and on and on. So sometimes it's hard to have to talk through conflicts, talk through barriers. It's hard to sit with families who are angry and be the recipient of some of that or all of that anger. I went to see a mom one day who I was told had made the decision that we were going to take her son off of life support. And there were 2 sisters there too, and I walked out to the waiting area behind the ICU, and I'd never met this woman before in my life, and I said, hi, Mrs. whatever her name was. I said, I'm Debbie, the palliative care nurse practitioner, and I was coming to see how I could help and introduce myself. And she looked at me and she said, frankly, you are the last person I want to talk to. I was like, hoping your face stayed okay. And I was like, that's okay. I said, I just wanted you to know who I was. But inside, I'm like, well, I just said hello. Like, come on, I haven't even offended you yet. But one of the sisters said, I want to talk to you. So we went and talked. So she was like, I'm so sorry about my mom. I'm like, no apologies. Skills. You have to be able to facilitate the meeting. You have to be able to listen, which is hard for most of us. We like to talk because when you're talking, you feel in control. When you're not talking, you're not in control. Or that's how we feel. Redirecting, problem solving, conflict resolution, mediating. Sometimes I feel like a marriage counselor, family counselor. Balancing support for the patient and family and support for your team. And there may be 5 teams represented there. And then your institution at large. So it's a lot of things in place. A lot of benefits. Hopefully all of you have participated in some type of family team meeting and seen it go well. We've probably all seen ones that didn't go well, but hopefully there's been good ones so that we are able to gather the information, they are able to hear the information. And so I put on here sort of phases to the family meeting. Planning. Why are we having this meeting? What are we hoping to accomplish? Where are we going to meet? We all know most hospitals don't have any private areas for family meetings. Sometimes we are left with out in the hallway. Not ideal at all. If there is ever a chance to have a space where you can go and sit down, and I actually just saw a picture the other day on a palliative medicine site, so I couldn't add it to this slide, because what it says was the most recent tool in the medical toolbox. And you want to know what it was a picture of? A chair. The newest intervention. Meaning we need to sit down. That is one of the most powerful interventions, is if you will sit your butt down instead of standing over people. Now, every now and then, that's not possible. I totally get it. I've had to stand at the bedside. But sitting down says, I care about you. I'm here. Interesting studies that have been done in the past about physicians coming, those who sat down with their patient, those that didn't. They surveyed the patients after the physician had been there for 15 minutes. That was the study intervention. When they came back to survey the patients and asked them how long the physician had stayed with them, they all estimated it to be 25 to 30 minutes, even though it was only 15 minutes. Asking, what do you know and how much do you want to know? Because sometimes we have diarrhea of the mouth. As soon as you get somebody there, blah, 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 blah. Right? We do. We got you now. We're going to give it to you, all of it right now. You see their eyes glaze over. Sometimes they get up and storm out. They can't hear it. So let's ask them. Delivery, being honest, speaking as simply as possible, as plainly as possible, even though that's challenging. We use words that we think are basic. We had a patient one time who thought DNR meant when one of our other nurse practitioners was talking to him, and she was explaining what resuscitation was, she said, so if you don't want that, then the doctor will put a DNR, do not resuscitate order. And he said to her, true story, I'm not making it up, oh, everyone has been asking me about that, and I couldn't figure out why they were talking about the Department of Natural Resources. Seriously, it was Shella who had a patient, and he was an engineer or something, so in his world, that made sense. Listening and then summarize. Key point for those of us who do this a lot, if we're having multiple teams come to be representatives, we all need to meet beforehand. Liver, lung, kidney, ICU, surgery, we all have to talk. Because worst thing in the world is we're in conflict in front of the family. We can be in conflict outside the room. We can talk about how we're going to present it so it's not conflict. But we need to have a brief little meeting. Who's going to lead the meeting? 2 or 3 people can't be the leader. What are we hoping to achieve? It may not be the outcome, but usually we're going in with a little bit of an agenda, right? But that agenda should not be the primary focus of the meeting. It is to allow the family to talk to us. During the meeting, let's introduce ourselves and what we do. Why we called this meeting. Ask what they understand. Let the family talk first. Doctors always want to talk first. Not picking on you, doctors, but you do always want to talk first. And sometimes if we ask the family, they have actually already reached some decisions. Because when we call to say, can you come in and meet with us at 4 o'clock today, what do you think they think we're going to talk about? They know we're not meeting to say, your loved one is doing so well. So a lot of times they've already processed, or you've already had other interactions with them, and now they're coming to tell us their decision. But if we start first and start browbeating them at the end, and I've had this happen, they go, we were already ready to tell you our decision. Let them talk. What are they hearing? Can you tell us, what did you just hear? Does this make sense? How does this jive with what you're thinking about? Make recommendations. I talk to the baby doctors a lot at Emory about, you have gone to school, you have gained a lot of knowledge, you paid a lot of money to be where you are. For attendings, for residents, for interns to be able to say, and our recommendation is, I say to families, the medical recommendation in this situation is that we not, or that we do. The whole menu approach of what do you want us to do? Not effective. In fact, in the AMA Code of Ethics, it says it should not be a menu approach. You should give your medical recommendations to the family or to the patient. So what I put on here, sort of lastly, helpful phrases versus not helpful phrases, which I just said one. So tell me about, as I said to you, tell me about your loved one. Tell me what kind of person they are. What gave them joy? What did they enjoy doing? What do you understand about what was just said to you? Or what do you understand about the 5 teams that have come to see you today? What are you hoping for? I hope that my loved one's metastatic cancer is going to be cured. My response might be, that is not likely to happen because it is so widespread. So if that's not a possibility, what would be your next? What would you hope for next? I don't want him to suffer. Or whatever it is. I wish we could. Very powerful phrase. I so wish I could make this better. I wish that we had the cure. I wish that we could. Because then you're aligning yourselves with them. You're joining them. What, if anything, could make a difference for you right now in this situation, in making decisions? What could help you? Is there anything? Yes, if we could just get one more CT scan of their brain, even though then you say they don't need another CT scan. But if that piece would help, and if it's a low risk, may not be where the patient is, but if it's low risk, is that something that could be negotiated? Why hasn't the infection team been called in for my loved one? Y'all have had them on 5 antibiotics. Don't you know which one to put them on? Right? How often do you hear that line? Because we've just gotten the culture back and we needed to change the antibiotic. I'm not making any decision until those infection specialists come. I've gone into the ICU, talked to a team, they're like, we don't need infectious disease. No, I'm not going to consult them. But what if? Not helpful. There's nothing more that can be done for your loved one. Who wants to hear that said? Because that's an untrue statement, is it not? It may be there's nothing more medically or surgically that we can do. But by God, there's always something we can do to ensure their comfort, their dignity, their care, our compassion. So those words should never come out of your mouth. Would you want us to try to restart his heart if it stops? How would you answer that? That doesn't sound that bad, does it? Yeah. Is that what we're really saying? That statement says we can restart their heart. When we know we can only usually restart it in less than 15% of all hospital resuscitation events. That's not what we're asking. But then when they say yes, now we have to backtrack and try to convince them of their answer is wrong because we asked a stupid question. And the most stupid question is, what do you want us to do? Dr. Fisher, I want you to do everything Stupid question, stupid answer. But if you happen to ask that question and they say everything, what should the next smart question be? What's the next smart question? What does everything mean to you? Most families don't know about third line, fourth line vasopressors. Do you want us to add a third vasopressor? We've had residents who've gone out to ask families. Now, come on. How long do you want us to do CPR? No. We are doing everything that can be done for this condition here at wherever, ICU that we are in. We are concerned. See, I always tell families what the team is concerned about. It's okay for you to tell them too. I am worried that by continuing everything we're doing, that we are actually causing them pain. I'm worried that if we keep doing this, we're going to whatever. I'm concerned that they're not going to live another 24, 48 hours, so I would recommend that you call your family. It's okay to tell them what we're talking about. What are we worried about? Tell them. And if I could, I'm not going to finish with the meeting piece, but if I could give any advice, although it doesn't factor in well in the year 2015, and there's data that contradicts what I'm going to probably tell you, but if I could give you feedback, not from Debbie the professional, but Debbie from the personal experience with family in an ICU, devastating brain injury in a 48-year-old who I knew would not leave the hospital alive when I left Atlanta to go there. I knew that after talking to the ER physician. I didn't say that to my sister when I got there. I didn't say it to his parents, my parents. But I knew, based on data, they, at that hospital, little bitty hospital, down at the beach in Jacksonville, part of Baptist system, they gave us some time. Because my sister was still at the beach when they both were struck by lightning. They were still covered in sand. And so, all of the talking, your families are in shock, and that's my message to you. Whether it's an illness that they've had for 20 years, whether it is by honey, see you tonight, they're in shock. And if we could just give them some time and let them walk the journey, love them, support them. I'm not saying don't tell them what's going on. Do what's appropriate. Tell them, but give them some time. We, I believe, would have a better family consensus process, because when they dig their heels in and you dig yours in, we lose. But ultimately, the patient loses. So thank y'all very much.